Students, today we are going to discuss about the second part of drug interactions. In the previous lecture, we have discussed about how the alteration of the absorption of the drug can take place due to the concomitant administration of the other drug. Today we will see what are the effects on the other kinetic parameters. Like alteration in the distribution of the drug. There can be lot of protein binding interactions. The drugs which are highly bound in plasma are potentially subject to the displacement from their carrier protein in presence of the another drug which also has the same affinity for the same protein. When another highly bound drug is added, there can be a competition between these two drugs and there can be a displacement of the one drug can take place. That will result in the increase in the free concentration of that index drug. This is then followed by the rapid redistribution of the index drug. The transient increase in the rate of elimination is created and that leads to the establishment of the new equilibriums for both the drugs. This displacement is only likely to cause some clinical significant effects if the index drug has a small volume of distribution or it has a narrow therapeutic index or has a rapid onset of action. So only in those conditions, such type of the drug interactions will become of more clinical significance. Let us understand some examples. Like here, I have given some examples. Phenylbutazone, if administered along with warfarin, warfarin gets displaced, its free concentration in systemic circulation increases, as a result of which there can be increased anticoagulant effect and which may lead to certain bleeding complications. Or if methotrexate administered along with salicylate, that will lead to the increased activity of methotrexate, as we all know that methotrexate is a cytotoxic drug. Valproic acid, if combined with phenytoin, it leads to the increased concentration of phenytoin, and as we have studied in pharmacology that phenytoin, if its concentration, free concentration in the systemic circulation increases, it starts following zero order kinetics. Even in cases of the liver diseases, the concentration of the protein, plasma proteins, will get altered, and sometimes there may be, due to the liver cirrhosis or damage to the liver, there can be a decreased albumin concentration, as a result of which the drug having high ppb value will not have sufficient number of proteins to get bound, and that will lead to the increase in its free concentration and therefore aggravation of the toxic effects of the drug. This is more likely to occur with the drugs which have high plasma protein binding ability. Let us understand what are the different interactions which can lead to alteration in the another kinetic property, and that is biotransformation. The drug metabolism, it occurs mostly in the liver and it involves the conversion of the active non-polar drug to the polar drug so that it can be excreted out of the body quickly. Generally, the less active or the inactive metabolites are formed. Occasionally, the metabolites are sometimes pharmacologically active in ways that are similar or dissimilar, including toxicity to the progenitor drug. The drugs which are extensively metabolized are particularly susceptible to various types of the interactions which can alter the drug metabolism rate. Most of the drugs which are metabolized by the several different pathways, making prediction of the consequences of metabolic interaction becomes in such cases very difficult. Many drugs have the potential to inhibit the metabolism. So when there is an alteration in the biotransformation of the drug, the concomitantly administered drug can either inhibit the enzymatic metabolism or will induce the enzymatic metabolism. Let us first talk about the enzyme inhibition. A clinically significant interaction may result and is dependent on the magnitude of the decrease in the clearance of the drug and the consequences of the resulting increase in a steady state serum concentration of the index drug. Now, most of the clinically significant interactions of such type involve hepatic microsomal oxidative enzymes, which can be divided into various subcategories as mentioned in this slide. Information regarding the predominant isoenzyme which is involved in the metabolism of the drug and whether the microsomal enzyme inhibitor specifically inhibits a particular isoenzyme is useful in predicting which type of the drug interaction is possible. The magnitude of the inhibition effect in an individual is sometimes variable because it depends on the specific enzyme or the enzyme inhibited and quantitative importance of that pathway in overall clearance of the index drug. For example, isoniazid is a potent inhibitor of microsomal oxidation of both carbamazepine and acetaminophen. With acetaminophen, conjugative metabolic pathway, that is a phase 2, predominates, resulting in clinically insignificant, that is only 15% decrease in the total plasma clearance of acetaminophen. Whereas in carbamazepine, the oxidative metabolic pathway is a phase 1 metabolism which predominates, and therefore isoniazid inhibits the total plasma clearance of carbamazepine by 45%. Which results into a steady state rise in the steady state serum concentration by around 85%, which is a very significant drug interaction. So in this case, the pharmacist should have a thorough knowledge about which type of the metabolic pathway is involved in metabolism of the drug, so that the predictions of the drug interaction due to alteration in the biotransformation of the drug become more easy. Mechanism of the second mechanism, that is the enzyme inhibition. The continuation with the enzyme inhibition. This varies from the competitive inhibition to the irreversible inactivation. Irreversible inactivation usually leads to the long-lasting effects. The time course of the change in the serum concentration of the index drug is affected by inhibitory interacting drug, and that is dependent on the new half-life of the index drug, so as to achieve or to reach to a new steady state concentration. What are the different interactions due to the altered renal excretion? The elimination interaction can occur when drug interferes with the amount of the blood flow in the kidney, or active tubular secretion, or the kidney tubular fluid pH. Because these are the three important processes which are taking place across the kidney. The one, glomerular filtration; second, active tubular reabsorption; and third, tubular secretion. So wherever a rate of excretion of the drug is going to get altered, any one of these three mechanisms are hampered. The renal blood flow and therefore the glomerular filtration rate is controlled partially by the vasodilatory autocoids, prostaglandins. If there is alteration in the synthesis of this prostaglandin, for example, indomethacin type of the drug can reduce formation of prostaglandin, then renal excretion of the psychotic drugs or the drugs which are used for bipolar disorder like lithium will get reduced. And if the excretion of the lithium is reduced, its toxicity in the body may increase because of its high serum concentrations. The mechanism of action of this type of the drug interaction is not very clear, as aspirin is a potent prostaglandin synthetase inhibitor but does not produce a similar effect as that of the indomethacin. Also, the clearance of the drug that are excreted entirely by the glomerular filtration are unlikely to be affected by another drug. In active renal tubular secretion, the drugs which use the same active transport system in the kidney can compete with each other for the excretion. For example, the probenecid given to increase plasma penicillin level by delaying its excretion. Both are organic acid, both are secreted by organic acid secretory pathway, and therefore the carrier proteins to which they are binding are same, and both compete with each other for binding to the secretory carrier proteins. Probenecid, being having a high affinity, wins the competition, leaving behind the penicillin into the circulation and thereby causing rise in the serum concentration of penicillin. But this interaction can be used to gain a therapeutic benefit by maintaining the levels of the penicillin higher for a longer period. This interaction can also lead to toxicity. For example, methotrexate toxicity can be caused by inhibition of its tubular secretion if it is co-administered with salicylates. Kidney tubular fluid pH is another factor which needs to be also considered. As we have seen in GIT, the passive reabsorption of the drug depends on the extent of its polarization or degree of ionization, and we have understood that the drugs which are in the non-ionized form undergo a rapid passive diffusion rather than the drugs which are present in ionized form. So only non-ionized drug is a lipid soluble and is able to diffuse back. At alkaline pH, the weak acid will exist always in ionized state, and therefore if the pH of the tubular fluid shifts to the alkaline side, then the acidic drug excretion, rate of excretion will get increased. So renal clearance is increased if the urine becomes more alkaline for acids, whereas at acidic pH, the weak bases will be excreted at a faster rate. Here I have given the example of the dexamphetamine, where 54.5 excretion at pH 8, whereas you can see 29% only at pH 5. Because dexamphetamine is weakly basic in the nature, at alkaline pH of urine, even high quinidine toxicity can occur. Urine acidification can cause increased excretion of the amphetamine, whereas urine alkalinization can cause increased excretion of the drugs like salicylates. Here I would like to get your attention to the barbiturate poisoning. Barbiturates, which are usually present in sedative or hypnotic tablets, if there is an intoxication with these sedatives containing barbiturate, then one of the remedy is to alkalinize the urine by giving systemically bicarbonates, so that the pH of the urine shifts to the alkaline side and the sodium barbiturate salts are formed, which are in the ionized form, and being in a salt form are water soluble and get excreted at a very faster rate. And that is how the barbiturate can be eliminated during intoxication rapidly from the body. So these are the interactions which are beneficial also. By altering the pH of the urine, you can even gain a therapeutic benefit, like especially to treat the toxicities. Alteration of the active transport. The quinidine reduces non-renal clearance of digoxin and reduces volume of distribution of digoxin, and that leads to the increase in the toxicity of digoxin. Verapamil, if combined with the digitalis, it inhibits its renal as well as the non-renal clearance, and that also leads to the increase in the toxicity of digitalis. Patients on high protein diet usually show the rapid rate of excretion of weakly basic drug like amphetamine. The protein in the body gets converted finally into the end product amino acids, which are weakly acidic in the nature, and therefore they can shift the pH of the urine to the acidic side, which will accelerate the rate of excretion of basic drugs. Even oxalates, which are present in many fruits and vegetables, can impair with absorption of the calcium, as it will form a complex with the calcium as calcium oxalate. Even the cabbage, peaches, pears, spinach, carrots, they reduce the radioactive iodine uptake by thyroid. Patients which are on the digitalis treatment, if consume salty food, that leads to the partial antagonism of the digitalis, and hence larger amount of the drug will be required to get a therapeutic effect, which may sometimes lead to the toxicity. As we all know, therapeutic index of digitalis is very less or is very narrow. Thank you.